Thank you, Oliver, for introducing me, and thank you, Jekko, for letting me present here. In my mind, sagittal balance is something that is very dynamic. It's not something that is fixed forever. And that is the item of my presentation today. I have nothing to disclose. When this generation starts, it slowly increases degenerative changes in the disc, and that alters the mechanical features of the disc. Often the patient reports a sudden onset of symptoms at loaded situation, and that is why many patients believe that this is traumatical, they have an injury, but it's not. It's a time thing that suddenly the mechanics were bad enough. This often leads to reflectoric tension and cramp in erector spinae muscles. Since they work all day long, they get stronger, and this might create a increased lordosis at the segments of degeneration, and then that creates further pain. Then the patient enters a vicious circle where the patient feels tired in the back muscles since they are always tense. They might be having more training and exercise to make them even stronger. Then they get even more segmental lordosis, and eventually that starts also to injure facet joints. And they develop a muscular imbalance with much stronger posterior muscles than the often weak abdominal muscles. And if this is not dealt with, the patients will not have the benefit of TDR treatment. And the benefit is the ability to alter lordotic curve according to position, just as Professor Lasenac told us about. With fusions, we normally perform a lumbar fusion, and we decide the lordotic curve that the patients will have all their life. This curve is calculated to be a nice curve for standing, but the patients do a lot of other things than standing, for example, sitting, and then the curve doesn't fit in. And this might cause primarily muscular pain and fatigue, but over time also tremendously increased risk of adjacent segment disease. That's why I've been doing this now for 25 years or a little more, and we've come to the conclusion that the patients have to have a preoperative program. This is to define what curve is it actually on their spine. What is a change over time by this muscular shortening, and what is actually their structure. How much have their dynamic lordosis changed over the years with low back pain? Most of the patients that reach us have had pain for quite a while, as you know. So we give these patients, before surgery, an intense program for strengthening of the rectus abdominis muscles and stretching, lengthening of the erector spinae muscles. And those stretches for the erector, they have to do like sitting at the desk or whatever every 15 minutes to really change it. And we recommend them to sleep in a fetus position, so they stretch out a little in their erector muscles during sleeping, and at least don't let them contract further. And as you probably know, all this has to be done anyway to get a good cervical result, because if the patient comes back after surgery and have a lot of muscular pain, the gain is zero. So this has to be done anyway, and it's beneficial to do it, most of it prior to surgery. In the preoperative evaluation, before I even decide to what type of surgery I would recommend the patient, I would look at the curve according to the Russelli scores and see what it looks like. And from those curves, I might say that this has to be a hybrid. The lumbosacral angulation is too high, so I have to make an angle, a lordotic ALIF and a TDR. But before deciding on that, the patient has to try to get back to what was believed to hers or his original sagittal curve before pain started, since this is very dynamic. On a preoperative evaluation, on the left you can see a case with two discs, mechanical discs, This patient managed to stretch the posterior side and strengthen the anterior side, so he or she could have a mobility in the spine. And on that other side, you see a case where there was the patient was not able to change the angulation at L5S1, so I did an A-lift there, but put a disc on top of it. And this is how things might fall out when you see these patients coming back after their preparations. Then we have to realize that during surgery, we implant cages or disc prosthesis on a disc degenerative segment. The disc is lower than it was when it was healthy, and we restore disc height suddenly. Then all the posterior structures get too short again. So with a mechanical TDR implant, it might tilt over. It's a high risk of that, and that puts a high load on the facet joints and probable further pain from them. With a viscoelastic implant that save the facet joints, since there's a counterforce in it, there will be strain and pain in these muscles anyhow. And that is why, even if primarily happy after surgery, the patients have to do their stretches for at least 6 months after surgery to conserve and maintain a normal balance between posterior and anterior musculature. This is not to limit mobility, it's merely to reduce a painful battle with muscles that affect the lordotic curve. If you see on this patient, on the flexion pictures, this wouldn't be possible if the patient hadn't stretched their lumbar muscles prior to surgery, because this is taken short after surgery. And still, there's a nice ability to have extension in the back, of course. And that means that the patient can adapt to different positions, can adapt to one curve when standing, another at sitting, and so on, without a lot of soft tissue limiting it. Sometimes it's just too late for TDR at a segment, even after the pre-op preparation. As you can see on these pictures, this patient with 2 segments of degeneration, with the lowest one severe, managed to restore mobility at the lower segment, but it was still too arthritic at the facet joints and so on to be meaningful to put a disc in, even if there was mobility after the preoperative preparations. So I did a combined, I did a A-lift, angled A-lift, and the disc on top of it. We have to provide our patients with tools and instructions. To make TDR surgery meaningful and successful, we have to engage the patients to do their homework prior to surgery as well as after. It's not a quick fix to have surgery. They have to be heavily engaged to give the good result. And to give them the right instructions, we need to cooperate with a skilled and educated physiotherapist. Some of that physiotherapist education you have to provide, because she or he has to know the goals to meet in the preparations. But this will give the patient the tools to take care of the lumbar spine. I'd like to thank Gecko for letting me present, and all the audience and the panel for listening. Thank you.